in the first-line advanced RCC setting, we have a handful of combination therapies which have become the standard of care, such that virtually all patients that have clear cell RCC, which is the most common subtype of kidney cancer, should be receiving these unless there's otherwise a contraindication. The backbone to these therapies is what we call immunotherapy. It would be a checkpoint inhibitor, a PD-1 agent. And we have two large categories of these combinations with the checkpoint inhibitor. There can be what we call an IO-IO combination, which would be using a combination of immune therapies with a PD-1 inhibitor. The one that's utilized and approved around the world would be a combination of nivolumab and ipilimumab, which is this anti-CTLA-4. So it's a dual approach at immune modulation, and that's been approved as frontline use for patients with intermediate and poor risk RCC. And then the other type of immunotherapy combination would be a combination of the checkpoint inhibitor with an oral targeted multi-kinase inhibitor, of which there are three major ones that have been approved. And the backbones for that are either pembrolizumab as the anti-PD-1 checkpoint inhibitor or nivolumab as the alternative. There are two pembrolizumab combinations. One is the pembrolizumab plus axitinib combination, and then there's the pembrolizumab plus lenvatinib combination. The nivolumab combination is nivolumab plus cabozantinib. And so those three are what we call IO-TKI combinations, are what doctors would be choosing from. And I've presented at our ASCO 2023 meeting the pre-planned final update analysis on overall survival with 4 years of follow-up of the lenvatinib pembrolizumab combination. Also at the meeting was presented 5-year overall survival and updated results of axitinib pembrolizumab by my colleague Brian Rini. So those four agents, again, an IO-IO and 3 IO-TKIs, are the primary therapies used, combination therapies used around the world for advanced and metastatic RCC in the frontline setting. There are going to be patients that are not candidates for checkpoint inhibitors, those patients that have ongoing chronic immune diseases, those patients who have organ transplants. Those patients, therefore, would not be candidates for a checkpoint inhibitor, and then we would be using a single agent oral TKI. And what's been approved in that setting would be a drug like cabozantinib as an oral agent, single agent, as well. And that was approved and shown benefit in intermediate and poor risk. And then you have the first generation oral therapies, of which sunitinib, pazopanib, axitinib, those therapies have been utilized. That, again, would be a much smaller population that would get a single agent. Most patients are going to be candidates for combination therapy. And then you had asked me to comment on, are there other experimental combinations? And the answer is yes, there are. There's combinations with a drug called belzutifan, which is a HIF alpha inhibitor that's been approved for patients with VHL syndrome that is showing benefit. It works also on the angiogenic axis by inhibiting HIF, which is part of the VEGF pathway. And experimental combinations using that belzutifan combined with checkpoint inhibitors are being performed. There is nothing ready yet for prime time with that. There is also studies looking at triplet therapy. There has been reports of a triplet therapy regimen of ipi-nivo, so 2 immune therapies plus cabozantinib, that had been presented and updated by Tony Choueiri, who was the principal investigator of that. That combination triplet is not yet ready for prime time either. There's obviously concerns of how much benefit are you getting with the added toxicity, and then the financial concerns of a triplet regimen. But there'll be future combinations coming out. For instance, there is a lot of focus on immune modulating agents that can be used to enhance the effectiveness of the checkpoint inhibitor. That can be up front trying to make colder tumors, if you will, hotter. And when I use that very lay terminology, I'm talking about making tumors that are not as amenable to immunotherapy into therapies which are more amenable to immunotherapy. And then there are combinations that will be coming forward that will circumvent or overcome what we believe to be some of the resistance pathways to immunotherapy that some cancer cells have. So I see the future of doublet and triplet and maybe quadruplet combination regimens as these different molecules come to be, you know, all having potential unique mechanisms of action and having additive or synergistic benefit. But the if you will, the primary entity is going to be that doublet combination, generally of an immune therapy plus one of the TKIs, oral therapies, and we're adding to that as we find molecules that are becoming more and more important.